1, 2,
And review, somebody female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's, charter book.
300 please.
I'll keep you on again.
Pulse check. No pulse.
No more pulse.
Yeah.
Here, what do the ECMO people say?
And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Welcome to today's deep dive. You are here because, well, you want to be the absolute sharpest, safest OB nurse on the floor.
Right.
And you want to completely crush your upcoming nursing exams. You've brought us a massive stack of notes on hemorrhagic conditions and, clotting disorders in pregnancy.
Which is a huge topic.
It really is. And our mission today is to act as your ultimate clinical mentors. I mean, imagine a biological state so extreme that a patient's body spends 9 straight months preparing for a massive hemorrhage.
Yeah, it's wild. The blood literally physically thickens.
Exactly. The body ramps up the production of these sticky clotting factors, and at the exact same time, it actively shuts down its own natural clot-busting system.
It's a biological superpower, really.
It is. It's an evolutionary marvel designed to save millions of lives during the profound physical trauma of childbirth. But what happens if that superpower triggers too early?
Or if it's applied to a patient who already has a clotting disorder.
Right. Suddenly, that life-saving mechanism becomes a ticking time bomb.
And that's exactly why we are aggressively applying the Pareto principle today. As your clinical coaches, we aren't going to just sit here and recite textbook bullet points at you.
No, nobody wants that.
Right. We are sifting out the 20% of high-yield concepts that will give you 80% of your exam value. We're focusing on what keeps mothers and babies alive.
The priority interventions.
Exactly. And the incredibly specific clinical traps your instructors really love to set on exams like the NCLEX.
Okay, so let's unpack this baseline physiology first.
Yeah.
Before we can even begin to talk about the bleeding, we have to truly understand the blood.
The foundation, yes.
Because pregnancy fundamentally changes a patient's hematologic baseline. Why is pregnancy such a complex hemostatic state to begin with? I know you mentioned the blood thickens, but what is actually happening at a cellular level?
Well, what's fascinating here is just the sheer scale of the adaptation. I mean, pregnancy is inherently a prothrombotic state.
Prothrombotic, meaning it wants to clot.
Yes, exactly. The liver kicks into overdrive and brilliantly increases coagulation factors.
Specifically factors 7, 8, 10, and fibrinogen, right?
You got it. And at the same time, the body reduces fibrinolysis. Fibrinolysis is the biological mechanism that dissolves clots once they've formed.
So you have more materials to build a clot and way fewer tools to break a clot down.
Exactly. Add in increased platelet reactivity, and the body is essentially building a dam over 9 months to prepare for the moment the placenta separates from the uterine wall.
Which is a massive wound, essentially.
It is. When that placenta detaches, it leaves these huge open venous sinuses bleeding directly into the uterus. Without this hypercoagulable state, a mother would, frankly, bleed to death in minutes.
Wow. That makes perfect sense biologically. But clinically, I mean, this creates a wild double-edged sword.
It really does.
It keeps the mother from bleeding out during delivery, but it sets the stage for massive catastrophic complications if things go wrong earlier in the timeline.
Right, which brings us to our roadmap for today.
Yeah, to really master this for your exams, we are going to trace this biology logically. We aren't just going down a random list of diseases.
No, that's how you memorize and forget.
Exactly. We're going to follow the progression of the placenta and the pregnancy, starting with implantation in the first trimester, watching the physical container adapt in the second, dealing with the mature placenta in the third, and finally,
looking at what happens when the underlying blood chemistry turns against the patient.
Right. That is the perfect clinical roadmap. So let's start at the very beginning of implantation.
First trimester.
Yeah. If bleeding occurs early, in that first trimester, the nurse must immediately put on their detective hat. You have to differentiate between 3 main culprits.
Spontaneous abortion, ectopic pregnancy, and molar pregnancy.
And the biological mechanism for each of those is completely different.
Really different.
So let's tackle spontaneous abortion first. Colloquially, patients call this a miscarriage, but on your exams and in your clinical charting, you will only see the term spontaneous abortion.
Right. Terminology matters here. The high-yield core definition is a pregnancy loss occurring before 20 weeks of gestation.
20 weeks is the cutoff.
Yes. And the statistics are, well, they're staggering. Estimates show that up to 26% of all pregnancies end this way.
Wow, over a quarter.
Yeah. And about 75% of the time, it's due to fetal chromosomal anomalies. The biology essentially recognizes that the blueprint is flawed, and it just stops construction.
To build on that, your role as an OB nurse really hinges on distinguishing what is biologically expected from what is clinically dangerous.
This is huge for exams, expected versus concerning.
Right. So if a patient is undergoing expectant management, meaning we are just allowing the body to pass the embryonic tissue naturally, heavy bleeding and painful uterine cramping are completely expected.
Right. The uterus has to contract to expel the tissue.
Exactly. But here's your priority assessment. The specific finding you must report immediately. It's the patient soaking more than 1 maxicad per hour for 2 consecutive hours.
Let's put a giant red circle around that for your notes. 1 pad per hour for 2 hours.
But why that specific metric? Like, what is happening physiologically when they cross that line?
Well, when a patient is soaking a pad an hour, it means the venous sinuses in the uterus are completely open.
Like a faucet.
Yes. And the uterus is failing to clamp down, or there is retained tissue acting like a wedge, keeping those blood vessels gaping open.
So they're just free bleeding.
Exactly. At that rate, the patient is rapidly losing intravascular volume. And along with that blood loss, if you see a fever, purulent, foul-smelling vaginal discharge, or maternal tachycardia,
The clinical picture has completely shifted.
entirely, you are no longer looking at a routine spontaneous abortion. You are looking at a septic abortion or impending hypovolemic shock.
That tachycardia is the alarm bell, isn't it? It's the heart desperately pumping faster to, circulate the dwindling supply of red blood cells.
Right. The heart is trying to compensate for the fluid loss.
So when it comes to priority nursing actions, you have to quantify that blood loss objectively. You don't just look at a pad and guess.
Never guess. You weigh the pads.
Yes. The golden rule of obstetric nursing. 1 gram of pad weight equals 1 milliliter of blood loss.
Write that down. 1 gram equals 1 ml.
And while you were doing that, another nurse is immediately checking the patient's blood type.
Which brings us to a massively testable concept, alloimmunization.
Oh, instructors love this.
They really do. If the mother is Rh negative, they must receive RhoAD, immune globulin.
Universally known as RhoGAM.
Right, RhoGAM.
So let's explain alloimmunization like I'm 5, because honestly, this is a concept that constantly trips up nursing students. What exactly is the Rh factor, and why is this such a threat?
Okay, think of the Rh factor as a specific type of protein jacket that red blood cells wear.
A protein jacket, okay.
Right. If you are Rh positive, your red blood cells wear this jacket. If you are Rh negative, your cells do not have the jacket, and your immune system has literally never seen it before.
So it's foreign to them.
Exactly. Now, if an Rh negative mother is carrying an Rh positive fetus, and she starts bleeding during a miscarriage, some of those fetal blood cells with the protein jacket cross into the mother's bloodstream.
And her immune system freaks out.
It acts like a bouncer at a club. It sees these foreign jackets, flags them as invaders, and builds permanent antibodies to destroy them.
Wait, the current pregnancy is already ending in this scenario, so why does it matter if she builds those antibodies now?
Because immune memory is forever.
Oh, wow.
Yeah. If she gets pregnant again in the future with another Rh positive baby, those maternal antibodies will cross the placenta and utterly destroy the new baby's red blood cells.
Which causes hemolytic disease to the newborn. That's fatal.
It is. So what does RhoGAM actually do? It acts like an invisibility cloak.
An invisibility cloak. I love that.
Yeah, we inject the mother with passive antibodies that find any rogue fetal cells in her bloodstream and cover up those protein jackets before the mother's immune bouncers can even see them.
That is brilliant. It prevents her from ever forming her own antibodies.
Exactly. It protects all future pregnancies.
Let's pivot to pharmacology. Because medical management of spontaneous abortion is heavily tested, you will frequently see the medication misoprostol.
Oh, misoprostol. High yield.
Right. It's a synthetic prostaglandin. And prostaglandins are the body's natural chemicals that ripen and soften the cervix and stimulate powerful uterine contractions.
We give it to help the body expel the products of conception.
But the patient teaching is where the clinical traps live.
Yes. Consider a clinical scenario. You are discharging a patient who just took misoprostol. You expect them to have cramping and bleeding. That's just the drug doing its job.
Right, that's expected.
But you must teach the patient to report black, tarry stools, severe unremitting abdominal pain, or diarrhea lasting more than 1 week.
Why the GI symptoms?
Because misoprostol doesn't just work on the uterus. Prostaglandins also heavily affect the gastrointestinal tract, causing increased gastric motility and potential of massive gastric bleeding.
Which explains the black tarry stools. That's digested blood. And if the patient becomes hemodynamically unstable despite the medication, meaning their blood pressure drops and their heart rate spikes, medical management goes straight out the window.
You're in emergency territory now.
Yeah, you are prepping them for a surgical intervention, the dilation in curettage, or D&C.
And post-procedure, they will likely be prescribed an antibiotic like doxycycline to prevent pelvic inflammatory disease.
And this is where we have to show, not just tell, the pharmacology trap.
Oh, absolutely. Imagine your patient is sitting on the edge of the bed, exhausted and grieving, and you hand her the doxycycline prescription. She tells you, I'm just going to go home, take this pill with a warm glass of milk, and try to sleep.
As an elite OB nurse, alarm bells should be ringing in your head.
Ringing loudly, because doxycycline is a tetracycline antibiotic.
And what does the milk do?
Dairy products contain high amounts of calcium. Tetracyclines are chemical chelators, meaning they magnetically bind to metallic ions like calcium, magnesium, and iron in the gastrointestinal tract.
So they stick together.
Right. If she takes that pill with milk, or an antacid, or an iron supplement, the drug binds to the calcium, forms this insoluble complex, and passes straight through her digestive system without ever being absorbed into her bloodstream.
She will get zero antibiotic effect.
None. You must teach her to separate doxycycline from dairy, antacids, and iron by at least 1 to 3 hours.
That is the exact level of detailed patient teaching that makes a safe nurse. And, from a psychosocial standpoint, we cannot ignore the emotional trauma here.
No, grief is fiercely nonlinear.
It really is. The patient might cycle through denial, anger, and bargaining right in front of you. Your role is deeply empathetic, shared decision-making, no platitudes.
Right. We do not say, everything happens for a reason, or you can always try again.
Those phrases completely minimize their trauma. We acknowledge the loss right there in the room with them. We say, I'm so sorry for your loss. I am here with you.
Because the emotional safety of your patient is inextricably linked to their physiological safety. A patient who feels unheard is a patient who won't tell you when their bleeding suddenly worsens.
That's such a crucial point. So let's move to our second first trimester complication. If a patient comes into the emergency department with early pregnancy bleeding and pain, how do we know it's not just a spontaneous abortion? What is the unseen threat we might be missing?
This is a massive distinction. And missing it is the #1 cause of first trimester maternal mortality. We have to definitively rule out an ectopic pregnancy.
The high-yield core pathophysiology here is implantation of the fertilized egg outside the uterine cavity, overwhelmingly occurring in the fallopian tube.
Almost always a tube.
Right. Now, the uterus is a magnificent organ built of thick, interwoven muscle fibers designed to stretch from the size of a pear to the size of a watermelon. The fallopian tube, on the other hand, is a delicate, narrow, rigid hallway. It cannot stretch.
That is exactly the visual you want. As the embryo grows in that tiny tube, the chorionic villi, which act like little roots trying to establish a blood supply, they burrow into the thin tubal wall.
Looking for nutrients.
Yeah. Eventually, they hit a blood vessel, or the sheer size of the embryo stretches the tube until it just snaps. It is a biological ticking time bomb.
Let's break down the clinical presentation, separating the expected from the drop everything emergencies. The hallmark finding of an early intact ectopic pregnancy is unilateral, sharp abdominal pain.
Pain isolated to one side.
Yes, combined with mild vaginal bleeding. But what are the massive red flags?
The danger report immediately findings are sudden, generalized abdominal pain, syncope or fainting, profound hypotension, tachycardia, or referred shoulder pain.
Let's zoom in on that referred shoulder pain, because that shows up on almost every OB exam. Why would a rupturing tube in the pelvis cause pain in the shoulder? That seems completely disconnected.
It does seem weird, but it comes down to anatomical wiring. When the fallopian tube ruptures, the patient begins hemorrhaging internally. Blood pours into the peritoneal cavity and pools right under the diaphragm.
Okay, the diaphragm.
And the diaphragm is innervated by the phrenic nerve. The blood chemically irritates that phrenic nerve, and because of how the nerve pathways travel all the way up the spinal cord, the brain misinterprets that diaphragmatic irritation as sharp, intense pain in the shoulder tip.
Wow.
So if you see unilateral shoulder pain in a pregnant patient with a history of bleeding, the tube has ruptured. They are bleeding internally.
Priority nursing actions for a ruptured ectopic are all about trauma resuscitation. You immediately establish large bore IV access. We are talking 16 or 18 gauge.
You need to pump fluids fast.
Exactly. You hang isotonic IV fluids to combat hypovolemic shock, and you rapidly prep the patient for emergency surgery, usually a salpingectomy.
Which is the surgical removal of the destroyed tube.
Right. But if we catch it early, if the fallopian tube is unruptured, the mass is small, and the patient is hemodynamically perfectly stable, we can avoid surgery entirely. We use medical management, and the absolute drug of choice here is methotrexate.
Alert, alert, this is a top-tier pharmacology trap.
It really is. Methotrexate is a heavy-hitting drug. How does it actually work to stop the pregnancy?
Okay, so methotrexate is a folic acid antagonist. It belongs to a class of drugs called antimetabolites. To understand it, think about what a growing embryo does.
It rapidly divides cells.
Right, it doubles over and over. To divide, cells must constantly build new DNA, and to build DNA, they desperately need the active form of folic acid.
Okay, so methotrexate steps in.
And physically blocks the enzyme that converts folic acid into its usable form. It literally starves the rapidly dividing trophoblastic cells of the molecular building blocks they need to survive, halting the growth of the ectopic tissue.
And because of that specific mechanism of action, the patient teaching is absolutely rigid. You must teach the patient to avoid all prenatal vitamins with folic acid and foods high in folate like leafy greens and fortified cereals.
This is critical. If they consume folic acid, it will completely counteract the medication, the embryo will continue to grow, and the tube will rupture.
Furthermore, they have to avoid NSAIDs like ibuprofen, which can cause fatal methotrexate toxicity in the kidneys. They must avoid alcohol, which strains the liver, and sunlight, because the drug causes severe photosensitivity dermatitis.
And highly critical for their future safety. They must use reliable contraception to prevent pregnancy for at least 1 to 3 ovulatory cycles after treatment.
Because the drug is teratogenic.
Heavily teratogenic. It will cause profound birth defects if they conceive while the drug is still impacting their system.
You know, it's also vital to acknowledge the real-world clinical environment context here. The landscape of obstetric nursing has changed. Depending on the state where you practice, vague wording in recent anti-abortion legislation has caused catastrophic delays in treating ectopic pregnancies.
It's a very real issue right now. Providers sometimes fear legal prosecution, hesitating while they consult hospital legal teams, even though an ectopic pregnancy has absolutely zero chance of viability and is an immediate threat to the mother's life.
What this means for you as an elite nurse is that your assessment skills, your swift advocacy, your constant vital sign monitoring, and your exceptionally clear, objective clinical documentation are more critical than they have ever been in the history of nursing.
You are the final safety net for that patient. Your documentation of falling blood pressures and rising heart rates is the objective data that forces medical action.
Absolutely. So let's move to our third first trimester complication. And honestly, this is the one with the wildest pathophysiology. What happens when the pregnancy test is blazing positive? The early pregnancy symptoms are intensely exaggerated, but there's absolutely no viable fetus inside the uterus.
You are looking at a biological imposter, specifically a molar pregnancy, clinically known as gestational trophoblastic disease.
Calling it an imposter is so accurate. Let's look at the true crime biology of a complete molar pregnancy. Normally, one sperm fertilizes one healthy egg containing the mother's DNA.
Right.
But in a complete molar pregnancy, a sperm fertilizes an empty egg, an egg that has somehow lost all of its maternal genetic material. The sperm duplicates its own DNA to compensate, but there's no maternal blueprint.
Which means no fetus forms at all.
Right. Instead, the trophoblastic tissue, the cells that were supposed to form the beautiful vascular placenta, goes totally rogue. It undergoes massive, rapid, chaotic growth, turning into a tumor-like mass of grape-like fluid-filled cysts inside the uterus.
And because that trophoblastic tissue is growing out of control, it is pumping out astronomical, dangerous levels of HCG.
Human chorionic gonadotropin, the hormone that triggers a positive pregnancy test.
Exactly. And the high-yield clinical hallmarks and the exam traps stem directly from that aggressively high HCG.
Let's list those expected hallmarks. First, the vaginal bleeding. It isn't described as bright red. The classic textbook description is bleeding with a prune juice appearance.
Prune juice. Dark brown, sometimes passing tiny grape-like vesicles.
Second, they will likely present with hyperemesis gravidarum, severe, intractable, debilitating nausea and vomiting.
To connect the dots, why the severe nausea? Because the nausea receptors in the maternal brain are highly sensitive to HCG.
And their levels are off the charts.
Right. In a normal pregnancy, HCG peaks around maybe 100,000. In a molar pregnancy, those rogue cells can push HCG well over 1 million. The brain is just overwhelmed with nausea signaling.
And here is the massive exam clue, the ultimate NCLEX trap. Preeclampsia symptoms occurring before 20 weeks of gestation.
This is a huge one to remember.
Let's give a quick primer on preeclampsia. It's a dangerous condition characterized by high blood pressure and protein in the urine, and it is strictly a disease of the late second and third trimesters. It requires a mature placenta to trigger the vascular damage.
Right.
So as an exam question gives you a patient at 12 weeks gestation presenting with a blood pressure of 160 over a 110 and proteinuria, your brain should scream, "That's impossible for a normal pregnancy."
Precisely. The massive overgrowth of the molar tissue tricks the maternal vascular system into triggering preeclampsia months before it is biologically possible in a normal gestation. If you see early preeclampsia, suspect a molar pregnancy immediately.
Your priority nursing actions for a molar pregnancy are entirely surgical. You rapidly prepare this patient for a uterine evacuation, usually a suction aspiration or a D&C, to just vacuum out the cystic mass.
And immediately post-op, you are going to administer continuous IV oxytocin. Because that cystic tissue was highly vascular and the uterus is extremely overdistended. Once the mass is removed, the uterus will want to remain relaxed, which leads to massive postpartum hemorrhage. Oxytocin forces the uterine muscle to clamp down tight and seal off those bleeding vessels.
But the critical care does not stop at the OR doors.
No, it doesn't. Because a lot of students assume that once the mass is vacuumed out, the patient is cured. The imposter is gone.
That is a deadly assumption.
Yeah.
If we step back and look at the cellular level, trophoblastic cells are incredibly invasive. That is their normal biological job, to invade the uterine lining to find a blood supply.
Right. And in a molar pregnancy, those highly invasive mutating cells can easily cross the threshold into malignancy. There is a very serious risk of gestational trophoblastic neoplasia.
Specifically, a highly aggressive, fast-spreading cancer called choriocarcinoma.
Exactly.
So how do we catch it if it's microscopic?
Through the HCG hormone. After the surgery, the patient must undergo serial HCG blood monitoring every single week and then every month for up to a year.
A full year.
A full year. We need to watch those HCG levels drop to absolute zero and stay there. If the HCG levels suddenly start rising again weeks after the surgery, it is the ultimate red flag. It means microscopic cancer cells were left behind and they are growing and multiplying.
Which leads to the absolute most important patient teaching for a molar pregnancy. Strict, highly reliable contraception is mandatory during this entire 1-year monitoring period.
And you must explain the why to the patient.
Right. If she gets pregnant normally during this year, her body will naturally produce HCG. That new normal HCG will completely mask the rising HCG from the developing choriocarcinoma.
The cancer could spread to her lungs and brain, and we wouldn't know it was there until it was too late because we'd just assume the HCG was from the new baby.
It is the perfect example of why rote memorization fails nurses. You aren't just telling her to take birth control pills. You're telling her exactly how taking those pills allows us to track the tumor markers that will save her life.
Absolutely.
That masterfully wraps the first trimester bleeding triad. We've seen how the body handles early failures. Moving into the second trimester, the initial bleeding threats might stop, but a new, completely silent threat emerges.
Cervical insufficiency.
Yeah, this is a heartbreaking complication because it happens so quietly.
Yeah.
The high-yield core definition is the painless, premature dilation and effacement of the cervix, leading to a second trimester loss or an extreme, often non-viable preterm birth.
Right. If you look at a transvaginal ultrasound of a healthy patient, the cervix is long and thick. But in cervical insufficiency, the cervix physically funnels and shortens, measuring less than 25 millimeters.
Top exam trap time. I see students constantly confuse cervical insufficiency with preterm labor. How do we keep them straight conceptually?
It's all about the mechanism of the physical change. In preterm labor, the engine is driving the change. The uterus is producing painful, regular, measurable contractions that physically force the cervix to open against its will. In cervical insufficiency, the engine is completely silent. There are no contractions. The cervix itself is structurally weak, and it just quietly gives way under the increasing weight of the growing amniotic sac and fetus.
The patient might not feel a single cramp.
Right, they might just notice a subtle change in vaginal discharge, like passing their mucus plug, or a vague feeling of pelvic pressure.
If a patient calls the triage line and reports increased pelvic pressure at 20 weeks gestation, we do not dismiss it as normal pregnancy discomfort.
Never, because if that structurally weak cervix opens enough, the intact amniotic sac, the bag of waters, will physically bulge and prolapse through the cervical os and into the vagina.
And if that sac ruptures, the pregnancy is over. It is an absolute emergency. The priority nursing action the moment you suspect or see prolapsing membranes is to immediately place the patient in the Trendelenburg position.
Head tilted down, feet up in the air.
We are using gravity to physically pull the weight of the amniotic sac off the failing cervix and simultaneously calling the provider for emergent evaluation.
For patients who have a known history of this, say they lost a previous pregnancy at 18 weeks due to painless dilation, what are our proactive medical and surgical interventions?
Well, medically, we alter the hormonal environment. We start them on vaginal progesterone suppositories around 16 weeks. Progesterone is the hormone that relaxes the smooth muscle of the uterus, keeping the environment as quiet as possible.
And surgically, the provider will intervene physically by placing a cervical cerclage.
Let's give you a memory anchor for the cerclage. Think of a cerclage as a heavy-duty purse string stitch. Imagine a water balloon where the knot is loose and the water is bulging out. The surgeon literally sews a durable synthetic stitch around the opening of the cervix and pulls it tight, mechanically tying the cervix shut.
It's usually placed prophylactically around 13 to 14 weeks of gestation. But here is the highly testable, absolutely critical nursing knowledge regarding the cerclage. Timing of removal is everything.
It must be removed strictly at 36 to 37 weeks. Why? Because the baby is term, and we need to allow the cervix to dilate naturally for labor.
Or, and this is the clinical trap, it must be removed immediately if the patient unexpectedly goes into active preterm labor.
Let's visualize what happens if you miss that detail.
Yeah.
If the patient goes into preterm labor, the uterine muscles start contracting with immense hydraulic force to push the baby downward. But the cervix is literally sewn shut with a high tensile synthetic string.
Right.
If you don't cut that string, the force of the contractions against the tied cervix will literally tear the cervix to pieces, causing catastrophic maternal hemorrhage and permanent anatomical damage.
We remove the stitch immediately to prevent the uterus from destroying its own cervix.
Okay, we have navigated the first and second trimesters. We are now entering the third trimester. And here is where it gets incredibly high stakes. This is the classic nursing school showdown, the third trimester heavyweights.
The big ones.
Two conditions, both causing massive third trimester bleeding, but with totally different pathophysiology, different presentations, and completely opposite nursing rules. Placenta previa versus placental abruption.
This is guaranteed to be a heavily weighted section on your exams. Instructors love to test these side by side because confusing the two in real life can kill a patient. Let's build a rock-solid comparison to eliminate any confusion.
We'll start with placenta previa. In a normal pregnancy, the placenta implants high up in the fundus of the uterus. In placenta previa, the placenta implants abnormally low, partially or completely covering the internal cervical eyes.
The analogy I love for this, imagine the baby is in a room and the cervix is the exit door. Placenta previa is like a giant, heavy, blood-filled bookshelf completely blocking the exit door.
That is exactly the right visualization. The hallmark presentation of previa is painless, bright red vaginal bleeding. Why painless? Because the placenta isn't tearing off the wall. The lower uterine segment is naturally stretching and thinning out as the third trimester progresses, which disrupts the placental blood vessels located over the cervix.
And because the bleeding just flows out the open door, there is no trapped blood building up pressure.
Therefore, the uterus remains soft, relaxed, and non-tender to the touch.
Contrast that mechanism with placental abruption. This is the premature separation of a normally implanted placenta from the uterine wall before the baby is born.
The analogy here, it is like violently peeling glued wallpaper off a wall.
Yes, the hallmark presentation is incredibly painful, dark, red vaginal bleeding. But here's the terrifying part. Sometimes the bleeding is completely concealed.
What makes concealed hemorrhage in an abruption so dangerous is the pressure. If the edges of the placenta stay attached but the center tears away, The blood pumps into that trapped pocket.
The pressure builds intensely behind the placenta.
This massive internal hematoma forces blood into the uterine muscle fibers themselves. The patient will experience agonizing knife-like pain. The abdomen will become rigidly hard, classically described as board-like, and the uterus will go into tetanic, nonstop hyperstimulation.
Let's talk priority nursing actions, starting with placenta previa, because there is one golden rule here, written in blazing neon lights for every OB nurse.
Never perform a digital vaginal exam on a patient presenting with unexplained third trimester bleeding. Walk us through the physical consequence. Why is it so dangerous?
Well, if a patient has an undiagnosed placenta previa, meaning that highly vascular bookshelf is sitting right over the cervix, and you blindly sweep your fingers into the vaginal canal to check for cervical dilation, your fingers will ram straight into the placenta.
You will puncture the placental bed.
It is like poking a hole in a high-pressure water main. You will cause an instant, massive, and potentially fatal hemorrhage for both the mother and the baby. You must keep your hands out.
You wait for an ultrasound to definitively confirm the placental location. If it's a confirmed previa, you assess fetal heart tones externally, monitor maternal hemodynamics, maintain bed rest, and anticipate a planned, controlled cesarean section at 36 to 37 weeks. They can never labor vaginally.
Now, priority actions for placental abruption. This is an entirely different beast. This is not a wait and monitor quietly situation. This is a high-pressure acute trauma scenario.
With a severe abruption, two lethal things are happening simultaneously. The placenta is tearing away, meaning the surface area delivering oxygen to the baby is drastically shrinking. The baby is suffocating.
And at the same time, the mother is bleeding into her uterus.
Your absolute priority is to assess for fetal distress. You are analyzing the monitor for a Category 2 or Category 3 fetal heart tracing, looking for late decelerations or absent variability, which indicate profound fetal hypoxia. You are immediately prepping the OR team for a stat crash cesarean delivery.
And while you are rapidly prepping for surgery, you have to monitor the maternal labs incredibly closely for a horrifying complication, DIC, or disseminated intravascular coagulation.
Let's break down DIC. The mother's body senses this massive internal bleeding behind the placenta. In a desperate attempt to stop it, the coagulation cascade goes into hyperdrive. The body sends every available platelet and clotting factor to the uterus to patch the tearing placenta, but it overreacts.
It's essentially a systemic bank run on the body's clotting materials. The body uses up all its raw fibrinogen and platelets, forming millions of microclots everywhere.
And once the supply is completely depleted, the blood completely loses its ability to clot. The patient transitions from hyperclotting to catastrophic hemorrhaging. They will start bleeding from their IV sites, their gums, their Foley catheter.
So, as the nurse, what specific labs are you watching to catch this transition?
You are meticulously watching the CBC for a plummeting platelet count. You are watching the PT and PTT, which measure how many seconds it takes for the blood to form a clot.
In DIC, the PT and PTT will be profoundly prolonged because there are no clotting factors left to do the job.
And you are watching fibrinogen levels crash. If you see those labs turning, you are immediately preparing to transfuse massive amounts of fresh frozen plasma, cryoprecipitate, and packed red blood cells.
And in these acute third trimester emergencies, if the abruption forces us to deliver the baby prematurely, say at 28 or 30 weeks, you need to have your high-yield neonatal rescue medications ready. The first absolute must-know drug is betamethasone.
Betamethasone is a potent synthetic corticosteroid given intramuscularly to the mother when the fetus is under 34 weeks of gestation. To understand why it's given, we have to look at the premature fetal lungs.
Inside the lungs are millions of tiny air sacs called alveoli. To breathe, these sacs have to pop open and stay open, but the inside of the sac is coated in fluid, which creates surface tension.
Imagine a wet plastic grocery bag. The sides stick together intensely. Premature babies lack a chemical called surfactant, which acts like biological dish soap to break that surface tension.
Without surfactant, every time the preemie exhales, their alveoli collapse completely, and they exhaust themselves trying to pry them open again.
So how does betamethasone fix that?
The steroid crosses the placenta, enters the fetal lungs, and essentially supercharges the type 2 pneumocyte cells, forcing them to rapidly synthesize and release mature surfactant. It artificially matures the fetal lungs in just 48 hours, massively reducing the risk of respiratory distress syndrome.
Your nursing implications for administering betamethasone are highly testable. First, it is a thick suspension medication. so you must shake the vial vigorously before drawing it up. It must be administered deep IM into a large muscle like the ventrogluteal. Never fall.
Warn the mother that the injection is going to burn intensely.
And crucially, because it's a massive dose of steroids, it will cause a transient spike in the mother's blood sugar and artificially elevate her white blood cell count. You must monitor for maternal hyperglycemia, especially if she has gestational diabetes, and differentiate between a steroid-induced WBC spike and true systemic infection.
The second massive high-yield medication in the preterm delivery toolkit is magnesium sulfate, specifically given when the fetus is under 32 weeks.
Now, a lot of students get confused because mag sulfate is used for multiple things in obstetrics. We use it to prevent seizures in preeclampsia. But here, in a preterm labor or abruption scenario, we aren't giving it to stop contractions.
No, we are giving it for fetal neuroprotection.
The pathophysiology of the extremely premature brain is incredibly fragile. The blood vessels in the germinal matrix of the fetal brain are paper thin. When a preemie is born, the stress of delivery causes massive fluctuations in their tiny blood pressures.
Those thin vessels often burst, causing a catastrophic intraventricular hemorrhage bleeding into the brain, which leads to severe cerebral palsy.
We infuse magnesium sulfate into the mother. It crosses the placenta and acts as a powerful vasodilator and cell membrane stabilizer in the fetal brain. It evens out the blood flow and protects those fragile vessels from rupturing during the trauma of birth.
But mag sulfate is a major high-alert medication. It is a profound central nervous system depressant. It relaxes smooth muscle systemically. Your priority in nursing action is to continuously monitor the mother for magnesium toxicity. What are the specific assessment findings that tell you she is becoming toxic?
You are performing hourly neurochecks. You are assessing her respiratory rate. If it drops below 12 breaths per minute, the diaphragm is too relaxed. You are assessing her level of consciousness. Severe lethargy or inability to rouse her is a red flag.
And the gold standard assessment, deep tendon reflexes. You tap the patellar tendon. If the reflexes go from a normal +2 to absent, the magnesium level is critically high.
The nervous system is shutting down and respiratory arrest is imminent. You immediately turn off the magnesium infusion, notify the provider, and prepare to administer the antidote, which is calcium gluconate.
We've spent a lot of time talking about the mechanisms of bleeding. Let's pivot to the final chapter, the invisible enemy.
We started this deep dive by talking about how pregnancy brilliantly adapts into a prothrombotic, hypercoagulable state to save the mother from hemorrhage. What happens when the patient enters pregnancy already suffering from an underlying clotting issue?
It creates the perfect physiological storm. We categorize these into inherited thrombophilias, like factor V Leiden, where the blood naturally clots too easily, and acquired autoimmune disorders, the most devastating being antiphospholipid syndrome, or APS.
Let's focus on APS because the mechanism is wild. It is an autoimmune condition where the body mistakenly produces antibodies that attack phospholipids, the crucial fat molecules that make up the membranes of cells, particularly the cells forming the placenta.
Exactly right. APS causes venous and arterial thrombosis throughout the mother's body, but locally it is a major culprit behind recurrent unexplained early pregnancy loss. The antibodies literally attack the forming placenta, creating microscopic blood clots that choke off the blood supply to the embryo, starving it of oxygen and nutrients.
When assessing these high-risk patients on the floor, we have to distinctly know what is an expected variation of pregnancy versus what is highly concerning. For example, mild gestational thrombocytopenia, where the platelet count dips a bit from a normal 200,000 down to maybe 120,000, is somewhat expected.
The mother's overall blood plasma volume expands by 50% during pregnancy, so the platelets are just more diluted.
But what is concerning, platelets rapidly plummeting below 100,000, or any clinical manifestations of a venous thromboembolism, a DVT. The hypercoagulable state combined with the heavy uterus pressing on the pelvic veins causes blood to pool in the legs.
You are constantly assessing for unilateral leg pain in just one calf swelling, warmth, and localized redness.
And if that deep vein clot breaks off, travels up the inferior vena cava, passes through the right side of the heart, and slants into the pulmonary artery, it becomes a pulmonary embolism, a PE. The manifestations of a PE are sudden and violent, sudden feeling of impending doom, acute shortness of breath, sharp pleuritic chest pain that worsens on inspiration, and rapid tachycardia.
That is a drop absolutely everything, call the rapid response team, and grab the oxygen moment. It is a leading cause of maternal death.
To prevent these fatal clots, patients with severe thrombophilias or APS will be placed on daily prophylactic blood thinners, almost universally Low molecular weight heparin, or LMWH like enoxaparin, injected subcutaneously throughout their entire 9-month pregnancy.
Wait, I have to stop and ask the obvious question. We spent the first hour talking about how we rely on the body's super clotting ability to survive the detachment of the placenta, and now you are telling me we are actively giving a daily blood thinner to a patient who is rapidly approaching childbirth, which is arguably the ultimate bleeding event. How do we not cause a massive, uncontrollable postpartum hemorrhage?
If we connect this to the bigger picture of clinical management, timing is absolutely everything. This is where high-level nursing coordination shines. LMWH must be explicitly discontinued at the very first onset of spontaneous labor, or held 24 hours before scheduled induction or cesarean section.
It's an incredibly high-stakes choreographed dance between the obstetrician, the anesthesiologist, and the nursing staff. Because it's not just about uterine bleeding, right? It's about the epidural.
Precisely. If a patient is actively on heparin, their blood is too thin to safely receive an epidural. When the anesthesiologist places that large epidural needle into the spinal space, they inevitably nick tiny blood vessels. If the patient can't clot, those nicked vessels will bleed freely into the enclosed spinal column, creating an epidural hematoma.
That expanding pool of blood will physically crush the spinal cord, causing permanent maternal paralysis. The heparin must be out of the system.
And postpartum, the dance continues. We don't just stop the medication and forget about it, because the risk of throwing a fatal PE is actually highest in the postpartum period, when the fluid shifts are massive, the patient is resting in bed. The LMWH is restarted typically 4 to 12 hours after birth, but only once the nurse has definitively confirmed that the initial uterine hemorrhage is fully controlled and the epidural catheter is safely removed.
While they are on this medication at home, your patient education must be incredibly thorough regarding bleeding precautions. It's not just the standard advice about using a soft-bristled toothbrush and an electric razor.
The critical teaching point that saves lives is about hidden bleeding. You must instruct the patient that if they experience any blunt force trauma, if they slip on the ice or bump their head on a cabinet, they must go to the emergency department for a CT scan immediately, even if they feel perfectly fine and there's absolutely no visible bleeding or bruising.
An internal subdural hematoma can expand silently over hours while on heparin, and it can be rapidly fatal.
We have covered an incredible amount of ground today, from the bleeding in the first trimester to the complex clotting cascades in the third. It is time for our final exam review. If you only remember 5 foundational concepts from this entire exhaustive deep dive to take into your NCLEX or your clinical shift, let it be these.
Number 1, if a patient presents with first trimester bleeding and sharp unilateral abdominal pain, your absolute first priority is to rule out an ectopic pregnancy. Hemodynamic stability, checking blood pressure, and heart rate is priority number 1, because a ruptured fallopian tube leads to fatal internal hemorrhage. And remember that referred shoulder pain is the hallmark of a rupture.
Number 2, if a patient develops classic preeclampsia symptoms, hypertension and proteinuria bizarrely early, before 20 weeks of gestation, immediately suspect the imposter, a molar pregnancy. And remember the why for patient teaching. They need highly reliable contraception and serial HCG monitoring for a full year post-op to ensure microscopic tissue doesn't mutate into deadly choriocarcinoma.
Number 3, you must master the difference in third trimester bleeding. Placenta previa is the bookshelf blocking the door. It is completely painless, bright red blood, the uterus is soft, and you never, under any circumstances, perform a digital vaginal exam. Placental abruption is peeling the wallpaper. It is incredibly painful, the blood may be dark or completely concealed, the abdomen is rigidly board-like, and it requires immediate emergent surgical delivery to save the hypoxic fetus.
Number 4, medication safety and mechanism of action are paramount. Methotrexate works by starving cells of folic acid, so patients must strictly avoid folic acid supplements to let the drug work. Betamethasone must be given via deep IM injection to mature the fetal lungs by producing surfactant. Magnesium sulfate is given to preterm infants for neuroprotection to prevent brain bleeds, and you must vigilantly monitor the mother for absent reflexes and respiratory depression, indicating toxicity.
And number 5, pregnancy is naturally a massive prothrombotic state. If a patient requires low molecular weight heparin for an underlying clotting disorder like APS, the absolute precision timing of stopping the drug before labor is critical to prevent spinal hematomas from epidurals and massive postpartum hemorrhage. And it must be carefully restarted postpartum to prevent fatal pulmonary embolisms.
You've got this material locked down. But before we sign off, as your clinical coach, I want to leave you with one last mind-bending concept to mull over. It's something that proves how deeply profound obstetric nursing really is.
I love these moments. Lay it on us.
We talked heavily today about tissues invading places they shouldn't, like a fertilized egg implanting in the narrow fallopian tube, or molar trophoblastic tissue growing wildly, or even normal placental cells invading the uterine lining. But consider the biological phenomenon of fetal microchimerism.
Microchimerism.
Yeah. During every pregnancy, thousands of fetal stem cells cross the placenta and integrate directly into the mother's own organs. They embed in her heart, her liver, her thyroid, and her brain. And they don't just disappear after birth. They stay alive and active in the mother's body for decades.
Wait, so a mother literally carries living pieces of her children inside her organs for the rest of her life?
Exactly. And the scientific mystery is what these cells are actually doing. While we as nurses focus so intensely on managing the acute emergencies of pregnancy, the massive hemorrhages, the failing cervixes, the dangerous clots, could these lingering fetal stem cells be acting as lifelong internal medics for the mother? Studies show that if a mother suffers heart damage years later, those fetal cells migrate to the heart to help repair the tissue.
Or, on the flip side, are these foreign fetal cells the hidden underlying trigger for the later development of severe maternal autoimmune clotting disorders like the ones we discussed?
It's a staggering physiological mystery. It proves that a patient is not just altered for 9 months. They are fundamentally, genetically, and forever changed by pregnancy at a cellular level.
That is absolutely wild. They carry their patients with them, literally and cellularly. Take a deep breath. You know this material.
You really do. You understand the why behind the interventions. Trust your training, review those 5 key takeaways, and walk into your exam or your next clinical shift with total, undeniable confidence. We'll see you next time.